or sometimes 3 times, sometimes 4 times every week. And we are happy to be today. We are having a very eminent speakers, and I can say from everywhere in the world. As I mentioned before, that we are talking together. We are having from USA, Dr. Ahmed Salam, and we are having from Europe, Dr. Paulo, and we are having Dr. Dogra from Asia, India, and Pacific, and from our Middle East here, Dr. Ahmed El Khashab and our area region. Before we start, I would like just to announce about our conference that will be in February, quick. Qasimi Ophthalmology International Conference. It will be held from 11 to 13 of February. It will be hybrid. So it will be physical and virtual, and most probably, most of it will be virtual. And I would like also to introduce our speaker today. We are having Dr. Paulo. Paulo is a chair of the Department of Ophthalmology, University of Sweden, and scientific director for the European Institute of Ocular Microsurgery from Italy. Dr. Paulo, hello. So everybody can see who is Dr. Paulo. This is our Dr. Paulo. And today he will give us a very interesting topics that there will be a lot of questions and discussions about it. Also, we are having Dr. Dogra, my dear friends. We met him last year in India, in Chandigarh, the best beautiful town in India I have seen. Dr. Dogra is a professor of ophthalmology, postgraduate institute, medical education and research in Chandigarh. He's a director of retina service at Grewell Eye Institute, Advanced Eye Center, Bigmer, Chandigarh. Is that all I have said correct, Dr. Dogra? Thank you. Also, it's my pleasure also to introduce my dear friends. We are seeing him every now and then, but we all the time miss him if we didn't see him every meetings. Dr. Ahmed Salam, he's an MD, PhD, FRCOF, Associate Professor, Retina and Uveitis, Director Uveitis Service, Jones Eye Institute, University of Arkansas for Medical Science in United States. Thank you, Doctor, for being with us. And lastly, I would like to introduce my dear friends. He is all the times my, what I can say, brothers, Dr. Ahmed El Khashab, a well-known figure in veterinary surgeon in our area, Middle East and internationals. He's a consultant ophthalmologist, with head of veterinary service in Eye Consultant Center in Dubai. This is the introduction for our speakers. And before we move to first speakers, I would like to invite also Lima. She will give a small introduction and talks on behalf of Bayer for all our attendees and speakers. Lima, mic with you.
Thank you, Dr. Muhammad. Can you hear me?
Yes.
Okay, I would like actually also to welcome everyone, either our honorable speakers and moderator for sure, and also all the attendees with us in the call. For us, this meeting especially is very actually special for us, because for the Vision 2020 meeting, which we have started almost last year in 2019, we have done 5 waves, and today for us this is the last wave of 2020 as our meeting, Vision 2020. It was a very tough year, but you have been with us virtually in our scientific meetings, and it always gives us the pleasure to have you with us. So hopefully it will be a nice meeting, and looking forward to seeing you next year, but with a better year, hopefully. So enjoy the meeting, and thank you again for the opportunity, Dr. Muhammad, and welcome to all the speakers, Dr. Dogra, Dr. Ahmed, and Dr. Ahmed Khashab as well, and our guest speaker today from Italy, Dr. Paolo Lanzetta. Enjoy the meeting.
Thank you, Lima, for this kind invitation for all our speaker and participants. And without any further delay, we would like to invite Dr. Paolo to start giving our first presentation. It will be about balancing vision and burden. Dr. Paolo, the mic with you, please. You can start share the screen and have. Thank you.
Thank you very much, Dr. Al-Amrai, for inviting me to this Middle East ophthalmology meeting, which I understand is very well attended. It's a great pleasure to join you and all the other prominent colleagues. I will have a couple of talks which are dealing with some tough topics, I would say, basically, because the first one is related to the burden of the intravitreal treatments we are giving to our patients. And the other one is related to the reinterpretation of some patterns we used to deal with during our retreatments. Give me 1 second for sharing the screen. Okay, here we go. I think that you can clearly see the slides now.
Yes, please. Yes, go ahead.
The first talk is, as I was saying, related to trying to balance the optimal outcomes we can get out of our patients with intravitreal anti-VEGF treatment and the burden related to the treatment. And we know that during the last, at least the last decade, we have basically learned that patients receiving intravitreal therapies in the context of real-world experiences, not in the context of registration trials, those patients may be often undertreated, and at the same time, they might create a burden which is usually due to unnecessary visits. So I think it's quite important to analyze and evaluate the available data and the literature with the aim to improve the quality and efficiency of our practices. You see in these slides that it is we all know that we have different levels of evidence depending on the different type of scientific literature, and you see that the highest level of evidence relies on systematic reviews, meta-analysis, and then we have as the lowest level of evidence some expert opinion documents. What we did recently was to perform a systematic review and meta-analysis on the current strategies and treatment options of diabetic macular edema in clinical practice. What we did a few months before was to do the same systematic review and meta-analysis in age-related macular degeneration. In this specific study, on diabetic macular edema, we included only studies with at least 12-month follow-up. As you can see here, we included 102 study population for a total of a very large number of eyes, more than 16,000 eyes. On average, there was an improvement, as you can see here, in visual acuity of almost 2 lines. And again, I'm sorry you cannot see the details of the graph, but I can tell you that most of the population were treated with either ranibizumab or aflibercept, and as expected, the PRN regimen was the most frequently used. Bevacizumab and dexamethasone implant were rarely the object of randomized clinical trials. This slide just wanna remind you that the results of this study are not the product of a meta-analysis of comparative studies, but they are a kind of a synthesis of published evidence, and they are extrapolated from single-arm studies or from multiple arm trials. So the statistical results when dealing with comparisons in terms of drugs or regimens should be taken cautiously. And let's move to the what we found with this meta-analysis. So when anti-VEGF only are considered within both randomized clinical trials and real life experiences, we noticed that fixed regimens provide the best outcomes in terms of visual acuity gain. As a result, fixed regimens exceed PRN approaches by 2.4 letters and 3 times 10 studies by 3.6 letters. However, I have to notice that there is a high variability in PRN results. Differently, when we do analyze only real-life studies, we do not find significant differences between different regimens. But again, a high variability is seen in studies with a PRN regimen. Fixed regimens show a trend to better outcomes for every anti-VEGF drug which we consider, as you can see here, ranibizumab, bevacizumab, and aflibercept. But this trend is not significant. However, again, fixed regimen seems to give the better outcomes in terms of visual acuity, obviously. The frequency of injections correlate with the visual acuity. Again, this is very similar to what we found and from what we know in another disease, which is age-related macular degeneration. And on general, 7 injections provide a gain of plus 7.5 letters. And on average, 1 additional injection produces almost a letter gain at month 12. When considering the drugs, aflibercept is the drug less dependent on the frequency of injection. And this is very important because many patients might not come back for the monitoring visit or for the treatment, especially those coming from far away. And in terms of outcomes, in both randomized clinical trials, or real-life studies, aflibercept leads to better results. Specifically, you can see that aflibercept brings plus 2 letters versus ranibizumab, plus 3 letters versus bevacizumab, plus 4 letters versus dexamethasone implant. But again, remember that this evidence does not derive from comparative studies and should be interpreted with caution. In real-life studies, when we do consider only those type of studies, aflibercept shows again better results. However, the difference is only significant, statistically significant versus the dexamethasone implant, and there is a difference of plus 4 letters. In terms of other characteristics of our patients, older patients have reduced visual acuity gain, and there is a loss of about 5 letters per decade in terms of age. Longer duration of diabetes is associated with increased visual acuity gain, plus 4 letters per decade. And as already known, lower baseline visual acuity correlates with higher visual acuity gains. In terms of morphology, baseline central retinal thickness does not correlate with visual acuity gain. So to conclude this meta-analysis, I would say that on general, the goal of DME treatment in the average patient should be a visual improvement of at least plus 7, plus 8 letters, or maybe 2 lines of visual acuity at 12 months. Unlike neovascular age-related macular degeneration, for diabetic macular edema, visual outcomes of real-world experiences may match the results achieved in most randomized clinical trials. And you remember that at the very beginning, when we started treating patients with AMD, in most cases, we couldn't obtain the very good results which were suggested by the registrative trials and randomized clinical trials. However, remember that there is a high variability in real-life studies and real-life results. Many factors might be involved in this variability. The role of treatment regimens, the time to access the therapy, the adherence to retreatment criteria, which might have some difficulties due to some difficulties in interpretation of the patterns. And obviously, as in wet AMD, the frequency of treatment remains a relevant factor. I would like to spend some more few minutes, just focusing on the, let's say, international guidelines or common guidelines, which recommend the use of aflibercept in patients with a visual acuity of less than 20/40. And you know that based on this evidence, different countries have set various rules for using different drugs based on baseline visual acuity. Maybe we will have some time for discussing this. Few minutes, because I would like to see an interesting indirect comparison of aflibercept and ranibizumab, specifically dedicated to a treat and extend approach. And this was the object of this recent publication. And the rationale for this is that both aflibercept treat and extend and ranibizumab in a treat and extend modality have shown a reduced treatment burden compared with other regimens such as the fixed regimen or the PRN regimens. And these, while maintaining the efficacy in visual acuity gains in a, let's say, long-term perspective. However, we know that randomized controlled trials gave us some outcomes with both drugs in a treat and extend approach in a limited follow-up of 1 year. And we don't have head-to-head data for both drugs in a treat and extend with a long-term perspective. You might be familiar with the rival study, the year 1 outcomes and the year 2 outcomes, but that specific study has some limitations in the design. So in this analysis, we completed this indirect treatment comparison and network meta-analysis for comparing aflibercept treat and extend versus ranibizumab treat and extend at 2 years, so in the longer term. And we consider visual acuity outcomes and treatment burden. This network meta-analysis was preceded by a systematic literature review of all the randomized controlled trials, which were assessing the efficacy and treatment burden of anti-VEGF therapies in patients with AMD in this specific case. And we identified 6 randomized clinical trials, which you see here summarized. Once again, regarding the rival study, at the time of this research and the later publication, the 2-year results of the rival study were not available. We created a network and link between aflibercept treat and extend and ranibizumab treat and extend at 2 years. We did apply, I will not go into the details of the methodology, but we did apply 2 methods, the 2-stage analysis, which link Altair to V1 and 2, and you see it on the left side of the slide, and the 1-stage analysis, which link Altair to ranibizumab treat and extend. Here you have the conclusion. So the network meta-analysis did not show a significant difference between aflibercept treat and extend and ranibizumab treat and extend in terms of improvement in visual acuity at 2 years. So similar improvement of visual acuities with the 2 drugs treat and extend. But when we did consider the burden or the number of injections needed, again at 2 years, aflibercept treat and extend was associated with significantly fewer injections compared with ranibizumab treat and extend. And the magnitude of the difference is quite considerable because it was approximately 6 injections in both main scenarios. And this is quite relevant in a 2 years time frame. So the key takeaways, you see them here. Anti-VEGF, we all agree that anti-VEGF drugs are the major advancement in therapeutic strategies for both diabetic patients and patients with wet AMD. We think that aflibercept has favorable characteristics that might allow optimal treatment outcomes in terms of visual acuity in both conditions with a minimized burden. And remember this point, which is very important because it's not only a matter of choosing the ideal drug, but there is also some important role in well-established and organized strategy for providing early access to diagnosis and treatment, adherence to treatment scheme, and treatment criteria and follow-up. And this is quite relevant in at least in the European countries where access is not always perfect, and also the adherence to the treatment and the interpretation of treatment criteria. So thank you very much for listening to this first talk, and I'm ready to have some discussion.
Thank you very much, Dr. Paolo, for this excellent presentation and on time, very nice, excellent. If there is any question from here, dear colleagues, to Dr. Paolo, Dr. Ahmed, Dr. Dogra, and I would like also, if anyone of our dear participants, they want to ask a questions, either they can send a question in here by writing a question to us, then we can answer that question, or they can raise their hand. I can directly have a talk with us and interview, or I mean interaction discussions. Any questions for Dr. Paolo, Dr. Ahmed Salam, Dogra, Ahmed Khashab?
Quick one for me. I mean, this is an excellent presentation. Thank you so much. I feel one way, especially when you're looking at real-world studies, is that to look at absolute vision rather than the vision gain. The entry criteria in real-world studies is very variable. For example, you treat patients with very good vision, or patients with very bad vision. Either may not be included in randomized studies. So I think absolute vision is a more accurate and more tangible vision than vision gain, than like lines of vision gain. So maybe what's the absolute vision of 65 ETDRS letter or 69 ETDRS letter between the 3 or 4 types of injections?
Yeah, I fully agree. I really agree. Then you might consider the possibility for the ceiling effect, for example.
Absolutely.
You know that the lower the vision is at entrance, at baseline, the more likely is that you gain some significant vision. That's correct. Yes, I fully agree.
And at the end of the day, that's what's important for patients, is driving vision and reading vision.
Yeah.
Okay.
I have a question.
Yes, Dr. Dogra, go ahead. Yes.
You talked about the fixed regimen and later on treat and extend. So in the meta-analysis, you clearly showed that fixed regimen is the best. But later on in a treat and extend, which is mostly we tend to follow these days, so you have shown that aflibercept has done better or with lesser injections. So what about the fixed regimen in that particular group? So that is what my question is.
Yeah, thank you for your question. And I think your question is quite relevant in the time of COVID-19 pandemics. And very curiously, the ideal regimen which can provide the improvement in visual acuity in the average patient, mostly in age-related macular degeneration, where there is greater experience. The ideal regimen means that on average, on year one, you have to give 7 to 8 injections. And very curious is to note that whether it is a treat and extend regimen or it is a fixed regimen, bi-monthly regimen, the number of injections you will give to the patient is exactly the same one, 7 to 8 injections. So I think the easiest way to treat the patient is definitely to apply a bi-monthly regimen, maybe with a aflibercept as per labeling. Treat and extend is a good compromise in between a fixed regimen and an individualized regimen in which you don't have the risk to undertreat the patient, because you have a minimum amount of injections which you give to the patient with a treat and extend. But still, you have to interpret the patterns in terms of OCT mostly in order to extend or reduce the interval time in between injection. And that might be a kind of a weak point of the algorithm. Yeah.
The problem is next year, as shown in DRCR-net, the injections are already gone down to half. And in third year, it is just about 2-3 injections. So how do we deal with that kind of a treat and extend down the line? Because AMD is different. We know, I mean, the injections are required and we can follow this regimen so that is what creates sometimes a problem for the second and third year in a DME case. So that is where the problem is.
Yeah, but it's also good that if you do analyze studies with a longer follow-up than 1 year, it's quite important to know that you move from the 8 injection year 1 to maybe 4 injections in year 2 and maybe less in year 3, which is fantastic, because at the very beginning we were thinking that due to the fact that diabetic retinopathy and DME are chronic diseases, those patients need many injections for many years, and that's not true, because by extending the follow-up time, it's likely that they need less and less injections, but they still need to be monitored, of course.
Thank you very much for all of you. I have maybe a last question, if there is no other colleagues here want to ask. Dr. Paulo, as you know, the numbers of injection in real world, they are telling it's about 4 point. That means for 4 injection per year or 5 maximum. And the adherence that mean is very less. How do you feel that we can apply this one if we are talking about treat and extend and the number of injection? Because what what we are talking about all the times, it is in a study rather than what is happening in the real life.
Yeah, this is a very good question. We have a very heterogeneous situation in Europe. There are countries in which the number of injections apparently is adequate. For example, if you consider UK has usually, on average, the best number of injections for both conditions, both AMD and DME. If you unfortunately consider Italy, the average number of injections are exactly the ones you were citing, 4 injections per year, year 1, which are definitely not enough for improving vision in our patients. I think it's not a matter of availability of vials and drugs, but it has to do with completely reorganize the clinics who deal with intravitreal therapies. So you have to create more slots for treating the patients, either in theaters or in some dedicated rooms, depending on the country where you practice and the rules. You have to have technology, OCT machines, nurses, and physicians. So it's a big challenge. And I can say that it's still a challenge in our country here in Italy, in some other European countries. That's why trying to apply a fixed regimen might render everything easier, and with the aim to give the right number of injections in the every patient. But if you have the capacity for doing that, you can switch to a treat and extend in order to limit the number of monitoring visits for the patients, so to limit the burden.
Thank you very much. Maybe we need to discuss this issue more. So, but we are having, so we need to go now to our second speakers. My honor to introduce Dr. Dogra to have a case presentation. Dr. Dogra, please.
Thank you very much, Dr. Muhammad, for inviting me. I'm going to talk about some subject which is a little more of a surgical interest here, and it's retinopathy of prematurity. And I'm going to share with you two cases here, which in fact, we have done a new procedure, which I'll just kind of elaborate to you. And basically, you know, our aim is to somehow spare a lens. That's how this lens sparing vitrectomy has established as a very important tool and is very important for managing as far as the surgery and ROP is concerned. And this phakic status, which we want to have, is something which will give a better outcome. And that is what we know. The success is good, but there are challenges. That lensectomy may be if it is a 4B, because you have most of the time this retina coming up very close to the lens on the temporal side. And lensectomy, like in one of the series here, was required in almost 35%. And in another big series, which is from a very famous center in US, it was required almost in 57%. So that is what our concern has been. And on that concern, we thought, can we have some different approach or a solution or a better solution? So we thought of a little new innovation in laser sparing vitrectomy, and that is what I'm going to present to you. The first case is this was an 8 weeks old baby. When it came to us at 8 weeks, a little bigger. In our country, we get bigger babies even with ROP. And there was oxygen exposure, sepsis, and neonatal jaundice. And that is the way it came. You can see here the arcade is already getting narrow, both eyes, and it was a 4A. That means at 2 months, and we took it up for laser. And despite laser, right eye did regress. Even the laser was done behind this raised area. And here, this eye progressed and was going almost into stage 4B. And ultimately, it did go into 4B and was like this. And so we thought of doing something which is different, which is not described. We put a cannula in the center on nasal side. The surgeon, like I was sitting on the nasal side altogether, everything moved, microscope was moved there. And this cannula was put in the center. It is never put on the center, usually on the side. And here, both these ports for the vitreous cutter and endoilluminator were on the other side. And so we also monitored this on our MIC OCT, which is part of the microscope. And I'll just show you this clip here, how we go about it. In this case, the 4B retinal detachment, where the whole retina is almost coming closer to the lens temporally. So if we had gone from a usual site or above, we would have to first do a lensectomy. So this is right in the center, nasally. The infusion cannula is placed, and this rather offered us the advantage that this nasal little bit of a bridge supported this cannula, and it was not touching the lens at all. And otherwise, many a time we have to do something for that. And these are the two other ports which I said, one for the cutter and other for the endo illuminator. And you can see, as you will see here, this was quite a tough case. It has progressed quite a bit, and you can see on OCT, the whole retina is going up and stretched temporally all the way. So what we did is, I think it is possible if we go from the side, there is enough place to manipulate your cutter. Your view is good. You don't come near the lens. That is a very important part. And as you can see here, you can achieve most of the surgical objectives. And here, what is being done is the vitreous is being removed. And once the vitreous is removed, and then we would like to remove this thick stalk, just cut it, because it's, I'm sure most of you are aware that the ROP surgery is different from the adult surgery. You can't go for removal of the entire thing like we remove in other cases. Here you have to cut whatever is possible without producing a retinal break. And that is what we did here. And ultimately, you can see here, this is almost coming to close end of the surgery, and we'll leave it here. And you can see now that intraoperative OCT is showing that it has gone down. So this is the way it looks like, and that is where we leave it. And now you can see the macula, the disc still, and you just do a partial exchange. You don't do full exchange. This is just air there, nothing else, no tamponade otherwise. And we tend to suture many a time because you don't want it to bleed, because if it is hypotony, then it will be. And you can see the results at 3 months. We had a very good outcome. And in fact, that is what is shown here. Even in 8 weeks, it has almost gone there. And that 3 months picture I have shown. And I'll show you another case. This came at 3 months. And here you can see 800 grams. This was a small baby, 25 weeks, blood transfusion, oxygen exposure, already lasered outside. And the way it came to us was like this, already lasered, already going into here 4B. It is the retinal detachment is coming into the foveal area. And other eye was fairly nicely regressing. And same procedure was done here. I would like to just a little different thing here, which we did. And why I wanted to show you this case, because something happened here, which was quite unusual. And same way, in the center, you put this infusion cannula, you go from the sides, and now the same way you can see here, the whole fractional retinal detachment is almost coming close to the lens temporally. So you don't want to go there. You cut this vitreous as much as possible. Here we used a small triamcinolone. You can do that sometimes. And try to do a limited, if you can remove the posterior hyaloid limited, only in few cases. Otherwise, it can be really damaging. You can't force it. Here you can see now posteriorly and hyaloid has come up. You can't go all the way to the periphery, but as much as you can remove safely, you do that. But what is also seen here is what you will observe, that we are not going all the way to the periphery. If we go to the periphery, we'll sacrifice the lens as well as the whole advantage of doing this procedure may go away. But another thing which you will observe here is, if you see this area, the macula here and here, there's a difference. But you can see the OCT, nicely it has gone back. And the same way partial exchange is done and the eye is closed. And what you see here is we had a good outcome, but the problem was there was a macular hole here. That was a problem, so which we never saw earlier. So we were worried that this macular hole is going to persist, but to our surprise, this macular hole disappeared of its own. And at day 28, we didn't find this. So that was a great thing. So this all nasal lens sparing vitrectomy to us appear ideal for 4B with extensive temporal traction retinal detachment. So we are happy to share with you that this has been accepted in Retina Journal ahead of a print in the month of May, which will be coming soon. And so we have in this 8 cases, where only 1 case required lensectomy. That also was an initial case where the lens touch was accidental, and the rest we could all achieve the aim. So in conclusion, I would like to share with you here is that stage 4B retinopathy of prematurity can present with extensive tractional retinal detachment approaching almost the retrolental space and achieving the surgical objective. Our objective is that how can we save the lens? And I think this all nasal approach appear a novel approach, and it did help us, and we did achieve all the surgical objective but without sacrificing lens. And all the surgical maneuvers could be done very safely. And that is what I wanted to share with you. Thank you very much.
Dr. Muhammad, you are muted.
I try. Oh, okay. Sorry. Thank you, Doctor, because I was very happy about the presentation, and we have the honor to be the first that we are seeing this technique. So thank you, Dr. Degra, very much. And I think many of colleagues here, they want to have a comment, Dr. Ahmed, Dr. Paulo, and Dr. Khashab about this one. What is your experience, Ahmed Khashab? So let's start in this way.
Dr. Excellent presentation. Thanks a lot for sharing it with us. I agree with you totally. Lens sparing vitrectomy for these babies is always our aim. My question is, where do you find the anti-VEGF role in, I would not say 4B and 4A, but in posterior ROP? Because I've seen that the laser is nearing or approaching the zone 1. So what do you think about the role of anti-VEGF in such babies?
Yes, you're right. In fact, that case was not lasered with us. It came from outside. It came late. Otherwise, most of the time at this stage, all zone 1 ROP, as well as aggressive posterior ROP, we give anti-VEGF first, and then subsequently we may laser if the need arises. Although the need is there in many of them, there are 2 advantages. One, that the laser at that stage may not be that extensive. We may not laser as much as about what you already highlighted, Dr. Ahmed. And secondly, it is sort of a synergistic effect of both the things, that we somehow may achieve better outcome. Otherwise, the simple laser also sometimes have an unfavorable outcome. So with these 2 combination of a first anti-VEGF in zone 1 and in aggressive posterior ROP, I think this has become a standard of care with us. And we just hold on, wait for the vascularization to progress. And in case the disease is coming back or if the retina is not getting vascularized, then we add laser in these cases. I hope I made my
definitely. And definitely the nasal approach is a great idea, actually, yes, to prevent this infusion even from touching the back of the lens. And this is a great idea, actually. I really like it.
I think it just came to me and I thought, and I'm happy that it got accepted in Retina so that some more people can try somewhere across the world. Otherwise, I was scared sometimes that if it's not accepted, then maybe it will not take up. So now we are happy about that. So they accepted in the May issue ahead of.
Great.
Yeah. Dr. Ahmed Salam, if you have any questions.
Yeah, no, I think this is great. And I think good luck favors the prepared. So that's fantastic. My question is just to, if you're sitting nasal, are there any like differences than if you're sitting superior in terms of axis, or you would do more or less what you would do if you're sitting superiorly?
Actually, Dr. Ahmed, that was our concern also. But
Right.
once we did the first case, and the baby is very tiny. You see, it's not ideal, perhaps, if we have a big person or a larger baby, and then it may not be a problem, maybe a problem. But here, it doesn't make a difference. Rather,
Right.
what we were doing earlier for such cases, we were trying to make this sclerotomy somewhere nasally only, but down. But then we had a very narrow between the two, because two ports were very close. But with this, we got enough, like we have as we are doing standard from above. So these are far away and we can manipulate nicely. So I think this came, and as well as most of the time in these babies, you know, the lens is globular. We tend to support this cannula up, otherwise it touches the lens. And here it was not required, because that nasal bridge, which is of course not that much high in these infants, it supported it very nicely. So it somehow came up as a very novel technique and helped us achieving all the maneuver which we wanted to do.
Thank you very much, Dr. Ahmed. Dr. Paolo, you have any comment or questions before we move to?
I was very interested in following, especially the videos on this brilliant proposal of moving nasal. We just published our experience in treating with lens sparing vitrectomy 4A robes with aggressive posterior robe. We didn't move nasally, obviously. The cases were less severe than the one you were showing, and congratulations, great surgery. We didn't use anti-VEGF. We just extended the laser, which was originally performed. And initially, the laser was done properly, but the babies progressed to this aggressive posterior. What we usually apply is a 25 gauge vitrectomy technique, and we use an illuminated infusion cannula. And the big concern, as you said, is the possibility that the cannulas touch the lens, and then you are in troubles. So great idea, I like it. Thank you for sharing it.
Thank you, Dr. Paolo.
Thank you, Dr. Dogra. Thanks a lot.
It means a lot to me. You've been guiding for so many things, a force. We look forward to your so many publications as well as presentation always. Thank you. Thank you.
Thank you, Dr. Dogra, for a nice presentation. And we would like now to move to Dr. Ahmed Salam. He will give a case presentation.
Sorry, just 1 second. Right, can you see my presentation?
Yes,
Ahmed. Okay, excellent. Right, okay, so this is a case about a patient who was referred to us from an anterior segment surgeon because of because of decreased vision, mainly in the right eye. And the patient history, he had chronic anterior uveitis. He was known to have ankylosing spondylitis, and he was only on no steroid drops, which was very mild inflammation, and no previous eye surgery. He was also under a neuro-ophthalmologist for a reason I'm going to show you in a minute. Now, his examination is 2200 vision in the right eye and 20/25 in the left. Everything with the anterior segment otherwise was fine, except very little cataract. I'm sorry, can I ask you, are you seeing like a big slide, a big like
yes? No, Ahmed, no. You can, if you have to make it a slideshow.
Yeah, I think there's a problem there. Just 1 second.
Doctor, you can try to escape, then play a slideshow.
Do what, sorry?
Do escape,
You need
escape.
escape.
Escape, yeah.
Yes.
No.
Okay, all right, thank you. Yeah, now it's showing that. Okay, all right. This is the funding of the anterior segment. So nuclear cataract slightly more on the right eye, a little bit of injection there, very size. And that's the fundus picture of the right eye where the problem is. And as you can see here, there's some area of optic nerve elevation there, and that was the reason he was under the neuro-ophthalmologist. And the left eye here, and you can see that the optic nerve looks fine. So this is again a picture of the right eye. That's a close-up picture of autofluorescence. You can see that the patient has, on the right eye, he got an epiretinal membrane here, which we'll show in a second better on the OCT. And then he got this appearance of the nerve here. That's his OCT appearance here. Sorry. That's the OCT appearance of the right eye. And with the thick epiretinal membrane, as well as the lamellar macular hole, as you can see here, but we still have the issue with the nerve. And that's the appearance of the left eye, which less severe, and he's not really troubled with this eye. So the problem is really, I mean, this patient has epiretinal membrane and lamellar macular hole, but how can we tie in what's happening with the nerve? And he was seen by neuro-ophthalmologist for some time. He went MRI, and they were heading towards lumbar puncture as well. So the main really point of this presentation is again to remind us of the vitreopapillary traction syndrome, and that was the case with this patient. The same problem happening with the macula, just happening with his nerve there, and that's was most likely the problem happening with his nerve rather than an actual disc edema. Right, this is a reminder again of his OCT of the macula. And then the question is, what's next? So we did surgery on him, we removed his lens, and we did vitrectomy. Sorry. Is the video playing okay?
No, not playing now.
Right. Let me just try something else.
Ahmed, if you can.
Yeah, it should be playing now. Just give me 1 second. All right, is it playing now?
No, we are not seeing the.
Oh, you're not. Oh, because it's paused. Resume share. All right, one more question. Is it playing now?
Yes, now
All
it's
right,
okay.
yeah. All right, okay. So that's the surgery. You took out his lens. This is the hyaloid, and he got vitreomacular and vitreopapillary traction syndrome. So that's removing the hyaloid. And then we had a look. Here is the intraoperative OCT. So the membrane is still there. And then we did, and I think intraoperative OCT is very nice, especially when there's a lamellar hole. You want to know really what's happening at the end, whether you converted this lamellar hole to a full thickness macular hole or not. So we're trying to peel here, sparing the fovea because it's very thin. Okay, so we went all around and just sparing the very central area of the fovea. And that's the appearance with the intraoperative OCT here. And then we just flush that with the cutter, just because the fovea is very thin. And then this is the appearance here. The fovea looks better. There's already no full thickness macular hole. So we left the eye just partially filled with air just for the leakage, to prevent leakage. And that's the appearance post-operative here, a few weeks post-operative. And this patient actually did fantastic. His vision came up to nearly 20/30, and he's really like one of the happiest patients. And he brought me his mother and his mother-in-law to treat, where they had cataracts. So he was very happy. So I think the main point is that, just a reminder, vitreopapillary traction syndrome is an important entity when you're considering optic nerve edema or optic nerve elevation. And that's another reason for getting an OCT on the nerve. You want to reassess this amount of edema, and then later on assess atrophy, and also look for optic disc drusen. And then another thing as well is to look for vitreopapillary traction, which interestingly in this study was shown to be present in nearly 50% of patients with vitreomacular traction and epiretinal membrane. So that's the main take-home message on this, just the vitreopapillary traction syndrome. And it seems that they do very well. This patient did fantastic, and I had another 2 patients as well that did fantastic with surgery. Thank you so much.
Thank you very much, Ahmed. Excellent presentation. And also, Dr. Ahmed Khashab, I know he will ask your questions. Sure. And Dr. Dogra. Okay.
I love the presentation, Ahmed. Excellent as usual. So do you think it is related to the uveitis, the ankylosing spondylitis, or is it idiopathic?
So we did an FA on him. I just didn't show here for the sake of time. And there was only like very little really leakage, was very, very minimal. And it didn't look really, it looked more like goes with the traction. Also, he didn't have much uveitis. What I didn't show here is also I put an Ozurdex at the end, and then I'm following him now for more than 2 years, and he really didn't have any active uveitis. I think it was only traction, because his nerves settled very nicely down, and his vision improved so much. So my feeling it was mainly traction, but that again was one of the differentials.
I mean the cause of the traction itself. So the epiretinal membrane and the papillary traction.
I think it's unrelated really, because it doesn't seem like he had significant uveitis in the past, and also in the period he was under me. So I feel it just like he's a bit unlucky with just vitreomacular traction and vitreopapillary traction.
Perfect. And in such cases, you do not use stain, dual membrane stain. Do you do ILM at the end to prevent recurrence of this epiretinal membranes or not?
So with the intraoperative OCT, if the macula looks fine, I just don't peel the ILM. I feel like less is more. In these cases and in diabetics, I feel just less is more. So if I get the intraoperative OCT and all looks fine, that's enough for me.
Okay.
Dr. Dogra, if you have, Ahmed, if you can stop share, please, for the presentation.
Let me check again.
Yeah. Dr. Dogra, if you have any comments.
Dr. Ahmed, I think one question already, I think, has been answered by you about the ILM peeling. Usually you may not do in all cases. We also follow the same. And another thing which sometimes we have seen this kind of traction also in some younger patients, where you have some kind of a combined hematoma. They may also appear the same way, where the disc get pulled up, as well as they have a ERM. So that is what another condition which we have seen this kind of way appearance. And I must congratulate for excellent surgery and the outcome which you got in this case. And I think this is important thing, that ILM peeling may not be required in all cases, and you have given an important message there.
Thank you so much. Very kind of you.
Ahmed, but this patient have already also, there is a lamellar hole, right?
Yeah, so he was, This was where we see was the these thick types of epiretinal membranes where they were associated with lamellar hole, and that's why I did not want to peel the ILM in him. I just wanted to do less is more.
Dr. Paulo, if you have any question or comments, you are mute. Okay.
Yeah, no, excellent case. Yeah, with a great outcome in terms of both visual acuity and morphology at OCT. Yes, I think the surgery was great, and I think that everything was helped by the size of the lamellar hole. Likely enough, the patient had a relatively small hole, and that helped a lot, but still, the final outcome in terms of OCT pattern is really beautiful. Yeah, congratulations.
Thank you so much.
Thank you, Dr. Ahmed. Thank you all. So now I will have my dear friend, Dr. Khashab. He will present about maintaining what's beyond macular edema. Managing what's beyond macular edema. See, old age that I have to make the phone close so I can see.
Oh, thanks a lot, my dear friend Mohammed. It is my pleasure actually to be today with you. So I will share my screen. Just one second. Okay, so managing beyond DME. So my talk is a bit of discussion about the role of anti-VEGF in proliferative diabetic retinopathy. So do we all think that treatment for proliferative diabetic retinopathy or severe NPDR is nothing but PRP, or there is a potential role of anti-VEGF? We're all aware of the protocol S, but let's go a little bit earlier about that. Both VEGF and placental growth factor are elevated in DME and diabetic retinopathy, but actually in PDR, the level of the VEGF is definitely much higher than in cases of DME. As well, the placental growth factor is significantly upregulated in eyes with DME and diabetic retinopathy. So these two elements are highly elevated in in diabetic retinopathy, in proliferative diabetic retinopathy. The progression of diabetic retinopathy, as we all know, goes in stages from mild, moderate, then severe non-proliferative diabetic retinopathy. Then we have the stage of proliferative diabetic retinopathy, which we all know with the new vessels on the disc or new vessels elsewhere. And with this, we have the diabetic retinopathy severity scale, and we can see that it goes in it divides the diabetic retinopathy into 13 levels with each level of severity indicating an increasing risk of developing diabetic macular edema or complications of diabetic PDR. More than two-step worsening is associated with an increased risk of subsequent vision loss over time. I have a quick case. This is a 34-year-old male patient. He's an insulin dependent for almost 17 years. On first examination, the visual acuity was 2100 in the right eye and 2050 in the left eye with an active PDR. This is the image. Actually, he's a renal patient as well, so I did not do fluorescein angiography, and I think the image is more than enough. We have some elements of NVD and NVE evidently apparent in both eyes, and there was a significant macular edema in the right eye more than the left eye. So after explaining to the patient that we need to tackle both the PDR and the DME, I opt to use anti-VEGF, and in this case, I used Eylea, which I felt more potent on the edema and on the PDR. And this is immediately after the first injection, total regression of the diabetic macular edema, and which persists with subsequent injections. And with this, I did not do any PRP. I thought, let's give it a try with anti-VEGF alone and see the result. So the edema is still regressing. The vision improved to 20/20 in both eyes. Actually, in the left eye, there is a very minimal epiretinal membrane, but it did not progress despite the, as we can see here, this is a bit of epiretinal membrane, very faint. Usually you keep an eye on it. And this is the OCTA showing even regression of the NVD and NVE that was present initially in both right and left eye. So I kept on following the patient, and he received 6 injections during the first year, and there is total regression of the new vessels. So I did not need to do PRP. This is not the rule for me. Usually I tend to do injections and do as well pan-retinal photocoagulation, usually far peripheral, not encroaching on the arcades. But I kept on following the patient, and he's very compliant, so I don't have the risk that he may progress out of my hand. Every time I'm just explaining to the patient that we may need PRP to decrease the burden or to decrease the rate of injections. But this highlights the importance of the anti-VEGF and Eylea in this condition to decrease the risk of progression of the PDR. So evaluating the impact of intravitreal aflibercept on diabetic retinopathy progression in the VIVID and VISTA study, we can see that a significant proportion of patients treated with aflibercept experienced regression in the signs of diabetic retinopathy. As we can see in VISTA and VIVID, almost 33 and 34%, and at week 148, we have even a higher rate of 45 and 50% of regression. And this is example of 2-step improvement in diabetic retinopathy severity scale in vivid diabetic macular edema after 1 year of intravitreal aflibercept. We can all see the disappearance of these microaneurysm and even the beading and of the blood vessels. And significant proportion of patients actually receiving aflibercept achieved more than 3-step improvement in diabetic retinopathy severity scale at week 100. There is a further evidence of this, the post-hoc analysis of the protocol T. This change in diabetic retinopathy through 2 years secondary analysis of randomized clinical trial comparing aflibercept, bevacizumab, and ranibizumab. And here we can see in year 1, the p-value, actually aflibercept, there was a greater rate of improvement in diabetic retinopathy severity scale in comparison to both bevacizumab and ranibizumab. We can see 76%, and in year 2, 70% in the aflibercept arms. Pan-retinal in protocol S, in which we have seen the difference in pan-retinal photocoagulation versus intravitreal ranibizumab for proliferative diabetic retinopathy. We can see that in this entity or in this study, the inclusion was mainly for patients with diabetic retinopathy with DME, and we have seen that there is marked improvement in the vision in cases with DME. while in patients without DME, there is about 1.8 letter of improvement, but still it is very significant to compare it with pan-retinal photocoagulation. Now we move on to a more recent study, which is the Clarity. And this one shows the clinical efficacy of Eylea aflibercept versus pan-retinal photocoagulation for best corrected visual acuity in patients with proliferative diabetic retinopathy at 52 weeks, 1 year. It is a multi-center, single-blinded, randomized controlled study. It's a phase 2B and non-inferiority trial. We can see that the patients are randomized 1-to-1 into pan-retinal laser photocoagulation and the aflibercept, and the primary endpoint was the mean change in best corrected visual acuity. The secondary endpoint was the change in the diabetic retinopathy severity scale. And the baseline, this is the inclusion: mild to moderate PDR, about 77% in the aflibercept arm, and PRP arm 74%, high risk PDR to advanced PDR in 22%, and 24% in the PRP arm. The exclusion criteria, and this is here is the difference from the protocol S: any coexistent ocular disease, and DME or any OCT showing central thickness of more than 300 microns due to macular edema. So no macular edema was included. Moderate or dense vitreous hemorrhage preventing clear visualization of the macula or optic disc or preventing laser treatment by mild vitreous hemorrhage is included. Fibroblastic proliferation or traction retinal detachment in the posterior pole, and previous history of vitrectomy or any other causes of retinal neovascularization. So the mandated treatment for the aflibercept arm is 1 month, 2 months, and 3 months. And then from week 12, we have visits where 4 weekly with PRN aflibercept dosing based on predefined retreatment criteria, while in the PRP arm, initial PRP at baseline, and in fractioned fortnights, so from week 12, visits every 8 weeks. We can see here that there is definitely favoring the aflibercept arm in the best corrected visual acuity at week 52, reaching to +4 letters. And the proportion of eyes showing total disease regression at week 52 is, with the aflibercept arm, 64%, 30% different from the pan-retinal photocoagulation. And to a lesser extent, the partial regression, 17, and here 44, and no regression only in 2%. And what about the presence of macular edema? So there was no macular edema, and this injection prevented macular edema from happening in 89% and the PRP in 71%. So what about the exposure of the treatment or the treatment burden? We have only here 4 injections, 4.4 injection, which is mimicking the actual, what you talked about, Mohammed, about the actual injection rate in diabetic macular edema, but here in a different proportion in the PDR. And the patients requiring supplemental PRP is only 2%, which is very minimal. So in summary, aflibercept with its inhibition of the VEGF and the placental growth factor leads to disease modification in DME, and more than 2-step worsening is associated with an increased risk of subsequent vision loss over time. In VIVID and VISTA, a significant proportion of patients treated with aflibercept has more than 2- and 3-step improvement in diabetic retinopathy severity scales, indicating regression of diabetic retinopathy. And similarly, in the post-hoc analysis of the protocol T, and it has definitely a disease-modifying, definitely an additional benefit beyond the DME. And in this as well, it's a point of discussion whether the anti-VEGF and the Eylea has an improvement in retinal perfusion. We all face these patients with marked ischemia and non-perfusion area. And we hope that we have a clue or we have a treatment for this sub-entity of patients. And in this, we have seen that there is some element of improvement in the perfusion with aflibercept, as we have seen here in the VIVID and VISTA. And this improvement in retinal perfusion was associated with improvement in diabetic retinopathy severity scale. So a last point of discussion, maybe you can open it. It's an open discussion. What is the role of anti-VEGF in PDR with only vitreous hemorrhage, neovascular glaucoma? We all use anti-VEGF, although it is an off-label, but we all use it in neovascular glaucoma, pre and post porcelain vitrectomy in advanced PDR, and in cases of non-perfusion or ischemia. Anti-VEGF and Eylea is not just in DME, and maybe this is, I'm talking specifically about the diabetic retinopathy, and in these cases, we have a valid point maybe to use Eylea as well. Thank you very much.
Thank you very much, Ahmed. Very nice and very excellent presentation, as usual, actually. And you open many points to discuss. Actually, this is our area. You see, so I become excited more now with you. There is only one question for Ahmed and for everyone here in our panels. Is it, are you going to treat a patient, let us say patient BDR, diabetic retinopathy, but without macular edema? Are you going to give only anti-VEGF? I know you have shown, Ahmed, some result about this one, but let me, as we are working here, how we are feeling about to give, how we are going to deal with the patient if we have seen a patient with diabetic retinopathy without macular edema. I will take Dr. Paulo, Dr. Dogra, and Dr. Ahmed, and come back to you, Ahmed. Yes, Dr. Paulo.
Yeah, thank you, Mohamed. I think this is a very interesting topic, the treatment of proliferative diabetic retinopathy with anti-VEGF. You know that in the US, anti-VEGF have been approved for treating patients with proliferative diabetic retinopathy in the absence of diabetic macular edema. And in Europe, ranibizumab has been approved for treating proliferative diabetic retinopathy. So it's quite intriguing. We have to separate clinical efficacy and yes, when we are dealing with clinical efficacy, anti-VEGF are definitely efficacious, probably both ranibizumab or aflibercept for treating proliferative diabetic retinopathy. We have always to bear in mind the concern of losing the patient to follow-up, because you need to continuously monitor the patient, whereas when you treat with laser with pan-retinal photocoagulation, it's a kind of a one treatment forever. It's also quite interesting that in the Clarity study, patients did receive 4 injections per year, year 1, for obtaining the control and regression of neovascularization. This is definitely less than what was obtained with ranibizumab. It's also quite interesting that in the mid-long term, longer than 1 year follow-up, the number of injections decreased considerably for maintaining the patient without neovascularization. In terms of ischemia and ischemic retina, the view of the US physicians is quite different from the one in Europe. And I'm referring to the beautiful work by Professor Godric in Paris, who nicely shows that there is no improvement in retinal perfusion by using anti-VEGF. And I would say that I'm mostly on that side. There are some nice imaging with OCT angiography of the peripheral retina, no improvement. And there was saying on the clinical efficacy. So no doubt that they are a good option. But in terms of cost efficacy, in the absence of diabetic macular edema, probably treating with anti-VEGF is not efficacious in terms of cost efficacy. But it's obviously quite fascinating options. Remember that in the long term, the visual field changes, which are dramatically in favor of treating with anti-VEGF during year 1. If you have a longer follow-up, those patients who are being treated with anti-VEGF still lose some visual field. Probably this is a proof that you're not improving the ischemia or the perfusion. So the ischemia is still there, and those patients are losing their visual field, despite the fact that they are not receiving laser destruction of the peripheral retina.
To finish with you, because already you have moved all points, what are the protocol you are using? If suppose there is no macular edema, how do you deal with, I mean, how do you manage these cases? I mean, what is the number of injection you will give? You will give 3 loadings or 5 loading dose and continue in the same way as we are treating macular edema, or there is something different?
Well, Mohammed, I said that ranibizumab has been approved for treating proliferative diabetic retinopathy in Europe, but it's not reimbursed at this stage in my country. So I'm not routinely using anti-VEGF for treating proliferative diabetic retinopathy. I'm using it in selected cases, and I refer to those florid cases, young patients with a very aggressive form of diabetic retinopathy, the so-called florid type of diabetic retinopathy. In those cases, I tend to use both anti-VEGF and scatter laser photocoagulation. But in a normal patient with proliferative diabetic retinopathy, I still use scatter laser photocoagulation.
Thank you. Is there any comment, Dr. Dogra, or to add something different?
He nicely covered most of the things. I would only add one thing here. We do find these cases of proliferative diabetic retinopathy coming late to us. They usually have proliferations. And if there is a proliferation, then this kind of a regimen, it doesn't work, because sometimes we might see contraction of these membrane and then we have more problem. So I think they had already excluded it even in the some of these trials, such cases. But that is a problem in a country like ours where they come late. So the rest of the things what Dr. Paulo has said, we absolutely agree the same way. And we treat mostly if it is macular edema with straight florid retinopathy, we'll give anti-VEGF. Otherwise, we'll do laser. Yeah.
Ahmad Salam, if you have anything
No,
to add.
I concur with Dr. Lanzetta and Dr. Dogra. The problem is there's a no-show rate of about 50% in patients with the diabetic retinopathy treated with anti-VEGF, even in the US. So I think it's a big rate. These patients are young, so I concur totally with them.
Dr. Khashab, if you have something to add.
Yeah, I agree with you all. Actually, that's the trend that we are doing as well. So the main treatment for PDR in my clinic is still definitely PRP. But in certain cases, as Dr. Lanzetta just mentioned, in florid PDR, actually I used the anti-VEGF initially and then do PRP just to decrease this florid new vessels. But what I wanted to highlight here is the actual effect, which we will be masked during the follow-up with, for example, for the diabetic macular edema. So when we are giving a treatment for anti-VEGF for diabetic macular edema, we need to see as well the periphery and make sure about the follow-up, because sometimes with the diabetic retinopathy severity scale, it will go down as well. So I agree with you all. I know the work of Dr. Goodrich in France about the OCTA. I think in the States, the initial work was with fluorescein angiography, and it showed initially that there is some improvement of the ischemia or decrease of the area of capillary dropout. And maybe longer term study maybe will be needed, because I think the study was in France was just for 6 months. But I think maybe longer study may add to our portfolio, maybe if this would be helpful or not. Maybe in the future.
Thank you, Ahmed. Thanks a lot. We will move now to also Dr. Paulo for the last presentation. He will talk about still a debate to tolerate.
Thank you, Mohamed. I think you can see my slide, my first slide. This is the presentation on the fluid, the role of fluid. And I think this presentation opens a debate on the degree of tolerance we want to have. And this is a controversial topic, the role of retinal fluid in patients with wet age-related macular degeneration. The point is, shall we tolerate it during the course of the treatment? And there are several data which suggest that there is a disconnect between anatomic and functional outcomes in those patients after the initial monthly doses. And here you see different types of fluid because the presence or absence of fluid in patients with wet age-related macular degeneration has a role both in the prognosis of the disease and also in the context of retreatment criteria, as I mentioned before, especially obviously in individualized regimens, namely the PRN regimen or treat and extend. And if you analyze how physicians behave, most ophthalmologists in different countries, they believe that disease reactivation during the course of treatment is directly related to the recurrence of retinal fluid. And that's why this is definitely a retreatment criteria for giving some new injections to the patients. Nevertheless, it has been shown that the relapse of the disease after the so-called dry period is secondary to the end of the intravitreal VEGF suppression, to the consequent reactivation of choroidal neovascularization, and finally to the drop of visual acuity. However, in the VIEW studies, post-hoc analysis suggests that overall, the retinal fluid does not have a marked impact on vision gains in patients treated with either aflibercept or ranibizumab, because they were the drugs used in the VIEW trials. And as you see, at 24 weeks, no differences in visual acuities were recorded in persistent dry or not persistent dry patients on your left side. And at 52 weeks, patients who showed no fluid or fluid outside the fovea or involving the fovea did not show difference in visual acuity improvements. In the context of age-related macular degeneration, two different fluid compartments can be distinguished, as you know, and as you can see here. Firstly, intraretinal fluid, which is usually associated to a worse visual acuity as compared to subretinal or sub-RP fluid, both at the time of the initial diagnosis or during the course of the follow-up. And secondly, on the right, subretinal fluid, which in the absence of intraretinal fluid is typically associated to better visual acuity, and mostly when it is present in a limited or residual quantity, it is not associated to a negative functional prognosis. So at least we have to differentiate in between intraretinal fluid and subretinal fluid. What summarizes in the previous slides has been shown in the ALTAIR trial, which is more recent, in which trial the presence of intraretinal fluid involving the fovea was associated to a worse visual acuity at the time of enrollment and the worst functional outcome after 2 years of treatment with aflibercept. Differently, as you can see, the presence of subretinal fluid did not negatively influence visual acuity, both at baseline or at the end of the study. Another recent trial, the ARIA study. In this study, both the absence of intraretinal fluid or the presence of subretinal fluid were associated to a better visual acuity. So we are now understanding the role of the different compartments. This is a slide from the more dated VIEW trial, which we know quite well. And the negative and positive association of intraretinal and subretinal fluid, respectively, have been confirmed with the final visual acuity after anti-VEGF treatment. Again, both aflibercept and ranibizumab. The same observation came from the old study, the CAT study, which included patients treated for 5 years with either ranibizumab or bevacizumab off-label. And then we have some interesting results from the fluid study. And this study has included patients assigned to treatment with monthly ranibizumab until complete resolution of both subretinal and intraretinal fluid, or to treatment with the same drug until the resolution of intraretinal fluid, only before extending the treatment interval. So 2 different arms. And both at 1 year or 2 years of follow-up, no differences in visual acuity gains in the 2 groups have been observed, as you can see here. And this is very interesting because those outcomes suggest that a kind of a zero tolerance approach with respect to subretinal fluid only is not needed and probably does not bring any improved outcome. We have also the Osprey trial. This is a phase 2 trial. In this trial, differences in central subfield thickness reduction between the new drug, brolucizumab, and aflibercept were not associated with differences in visual acuity gain. This is a phase 2 trial. And then we have the 2 more recent phase 3 trials. You might be familiar with those trials, the Oak and Area studies. Again, brolucizumab was compared to aflibercept in a phase 3 trial. Less patients treated with brolucizumab presented both intraretinal and or subretinal fluid during the course and the conclusion of the trials, as you can see here. But however, this is important because this morphological difference did not translate in a functional outcome in favor of brolucizumab. And both drugs, in fact, determined similar improvements in visual acuity. At this stage, and based on the evidence presented, we have to revise the traditional criteria used for guiding retreatment with anti-VEGF after the initial phase. In the context of individualized regimens, we know that visual acuity loss is far from being an ideal criterion because what is lost usually cannot be recovered with reinjections. And we have some proofs from the early trials with ranibizumab. Hemorrhage in the second part of this slide is still, I think, is still a valid sign of active or reactivation of the disease. And we know now, after the data I presented to you, that some residual fluid may be tolerated without visual outcomes being compromised. So I would say that modern retreatment criteria should consider to tolerate let's say some amount of subretinal fluid, while still allowing an extension of the treatment intervals if we are approaching the patient with a treat and extend regimen. In the ALTER study, almost 9 and 7 letters, as you can see here, of visual acuity gain at 1 and 2 years respectively were obtained with a mean of 7 injections during year 1 and less than 4 injections during year 2. And as you can see here, up to 60% of the patients reach a treat interval of at least 12 weeks or longer, and more than 40% of 16 weeks. This is very relevant, still tolerating some amount of fluid because this was in the retreatment criteria. And also, I would say that encouraging outcomes were also obtained in the ARIA study, which also tolerated some residual subretinal fluid. So just to conclude, I think that many data suggest that there is a disconnect between the anatomic and functional outcomes in patients with age-related macular degeneration after the initiation phase. There is some strong evidence now that suggests that intraretinal fluid has a negative effect on the visual outcomes, whereas we can say that the presence of some subretinal fluid, and we should better define what some means, in the absence of intraretinal fluid has been associated with some good visual acuity outcomes or visual acuity gains during the course of the treatment. Coming to the type of regimen, maybe that a proactive treat and extend regimen with aflibercept may achieve some good initial visual acuity gains, and those gains can be maintained for at least 2 years without forcing complete fluid resolution and without giving some unneeded injections to the patients. I think this concludes my presentation. In the case I have some few more minutes, I would like to share with you some few slides from the Vision Academy on the recommendations on the management of fluid, and more than that, a single case presentation in which we combine some kind of tolerance with respect to the fluid and treat and extend approach. Thank you very much.
Thank you very much, Dr. Paolo, for this excellent presentation. And also you have highlighted a very important points about the treatment and the difference between the functional and anatomical difference in the management of macular edema, either in diabetic or in case of AMD. Is there any questions to Dr. Paolo or comments? We have 2 questions actually. If there is no question, Ahmed, yes, you have any questions?
Yeah, thanks a lot. Excellent presentation, Dr. Paolo. It's great. So the differentiation between the intraretinal and the subretinal fluid is very important. And I think maybe you can present this with your case, but when do you stop if you have a subretinal fluid? When you feel that there is no much of improvement, initially you try to dry it up, but if there is persistent subretinal fluid and there is no more improvement in the visual acuity, I think that's the time to conclude that this subretinal fluid can stay and maybe it has a protective effect of the RPE. Do you agree with that?
I do agree. Obviously, at the very beginning of the treatment course, you want to get rid of all the fluid for the benefit of the patient. And that's why the initial phase with at least 3 initial injections, independently from which drug we are using, is important. But then when you do reevaluate the patient, if you see some residual fluid or some amount of fluid, most physicians now believe that it's not needed to fully remove that fluid. Obviously, the term of discussion is how much can be tolerated. And for saying that, I think that if you see the patient coming back and the residual amount is always there without any compromise in the visual acuity, that's the case in which you don't want to really challenge the fluid and target the fluid by giving some unnecessary injections to the patient. As you suggested, geographic atrophy is, yes, part of the natural course of wet age-related macular degeneration, but there is still this aspect that repeated injections with anti-VEGF might promote some RP changes, RP atrophy, and definitely and ultimately geographic atrophy. So I think it's really important to give the proper number of injections at the proper time to our patients.
Thank you very much. If you want to say something, I can say we have to treat the fluid and to the maximum that we can to dry. If not, then we have to maintain. I think this may be a conclusion if you are agree on that. So we have to treat the fluid, the patient, till the maximum that we can decrease. After that, we have to maintain on that. Otherwise, if we are going up and down, it will be another problem that it will lead to apoptosis of the receptors, and it will lead to ischemic changes and loss of vision. Is there any comments, Dr. Dogra, Dr. Ahmed? Salam?
No, I totally concur.
Dogra, please. Any comment?
I think absolutely what Dr. Paolo said and subsequently Ahmed added, that is the way. It is the, I think, residual fluid. Otherwise, our indication of retreatment was always appearance of fluid. So that was the indication all the time. But if this residual fluid, which is not going away and it is not decreasing the vision, what Paolo said, I think that's the key. Absolutely.
But we have to say at the end also is there is still a debate. Yani some people, they are believe fluid is whatever the fluid available, it's a pathology because it's not available, it's not there before. So yani, but it's still a debate about this one, but maybe it's we are all the people going toward minimum, it cannot affect or make any difference. We have I think 2 questions, maybe someone answer that questions. Okay. Role of anti-VEGF in submacular. So you already sent an answer, no need to discuss. Okay, I think Lima, I think she asked me to present one video, small video. If you are ready, if you can share, Lima. That's.
I think Razan, you will be sharing, or if we are out of time, we can have it next time.
Lima, you have it or you don't have it? The video.
Yeah, we have it, but we were planning to do it next time because now we're running out of time, so no need. It's okay, doctor.
Okay. Anyway, thank you very much for all of you. Thanks for our very interesting discussions and this nice information and good gathering, eminent speakers involving, I think, the whole the world. So we are having from everywhere one representing of our doctors. I would like to thank also Bayer for sponsoring this meeting. Thanks for also our management event, and very special thanks also for attendance, for being with us. And very, very special thanks also for Dr. Dogra, because now it's a midnight in his place, so we keep him late, almost 12 and something. Thanks a lot for all of you, and we hope to see you, inshallah, in next meeting. Thanks a lot, and good night.
Thank you.
Thank you all.
Thank you.
Have a nice day. Good night.
Thanks for all the speakers. Thank you very much.
It's been a pleasure.
Bye-bye.
Absolutely.
Bye.